Good afternoon. This is Delane Henry, CEO of Advanced Hospice Management. I want to thank you guys for joining me today. I'm going to just give a quick introduction for those who maybe haven't joined us on a prior webinar. And I will also give some time for those who have not quite signed in to have a chance to join the call. Again, this is Delane Henry, CEO of Advanced Hospice Management. We are a full-service, third-party, hospice-only billing company. We're independent, which means, we're a billing solution for any and all softwares. We use whatever program you guys use as a client. We're integrated with Ability and those other types of clearinghouses, that anything that we can do to help move your claims quicker, we are definitely wanting to be part of that process. Our billers are geographically dispersed. We have billers that live across the country, which gives us great experience with the different MACs and in different states for Medicaid programs and managed care programs. We always have a primary biller assigned to every client's account, but we have a full billing team as a backup, which is fantastic for those who've ever experienced a biller out sick or unexpectedly on leave, or unfortunately sometimes leaving permanently without notice. We have a 24-hour emergency hotline. We work collaboratively with our clients through all aspects of billing. We have an exemplary level of customer service. We provide continuous education to our billers, and that information is always shared with our clients. Our goal is to maximize collections for all of our clients and to collect more of your money faster, which gives you guys a way of budgeting and planning that provides a more predictable cash flow. So those are our attributes, and we really appreciate you guys joining our call. And just throughout this call, keep in mind, if there's anything that you guys have further questions on, of course, we'll have a question and answer at the end of the webinar. But if there's something more in depth or detail that you maybe want to cover, you're always welcome to reach out to us. We are always available to answer questions. We want to get the right information into the hands of those people who need it most, which are the agencies and the billers who are taking care of patients in our community. So let's get started. If you received our newsletter, which I'm sure most of you guys did, that's how you signed up for our webinar, you know that we covered the new ability to file electronic notice of elections. So now we can do that, but there's a few glitches that we've discovered. Change request 10064 was issued by Medicare, and it outlined the process for filing electronic NOEs via the EDI system starting January 2nd, 2018. However, we discovered some MACs were not ready to receive those electronic notice of elections, and many software programs were not ready to send them. So Palmetto issued a statement that they had a problem when testing the electronic NOEs. They were hit with an edit, which means there was something electronically that kicked that NOE back, and it was returned to provider with a edit E2101. And so they are saying that they will not have a fix in place for that until February 5th. And when that fix is implemented, they will issue a statement. So below that, and you guys will all get this handout, but that is the link to the original issues from Palmetto. We've not seen any other issues on CGS or NGS or the other MACs that indicate that they were not ready to accept these notice of elections. So this is the instruction that was given to us by Medicare University about how to file these NOEs. So what I've included in the slides is just for your knowledge as a biller, administrator, anyone in the office who needs to understand how this works and what data is going to be required on these electronic notice of elections. But in the actual handout for Medicare University, which we gave the link to in this webinar and also on the newsletter, there are technical components for programming, which I didn't include because I don't think anybody's actually programming their software to do this. They have software, people who do that at the software company themselves. So I left out the technical stuff. I included what we want to know because I'm sure in most software platforms you should be able to print that notice of election prior to submitting it electronically, or at least view it on your screen in a UB04 format, so you can be sure that all the elements necessary are present before you submit the claim. And then once you're sure all of that data is there, you can send a test claim over and then go look at it on the Medicare side and make sure it went over correctly and that the elements are still there in the right place, and confirm that your process is working correctly. So according to Medicare, all of the different types of notice of election should be able to be sent electronically. One thing Medicare wants to caution us about is all of the NOEs have to have Medicare as primary on the claim. So if you have a patient with a Medicare as a Medicare secondary payer, maybe they have Blue Cross primary or another insurance primary and Medicare secondary, in order to submit that NOE electronically, Medicare has to be listed in the primary position. It will not, Medicare system is not capable of taking a claim for an NOE if there's something other than Medicare in that primary position. So what we want to do, and just in consideration, you may have to make some changes in your software. Initially, just put the patient in as Medicare, submit the notice of election, and then enter your primary payer in the correct location and move Medicare down to your secondary payer. So that's definitely a consideration that you need to remember when attempting to submit these notice of elections electronically. Tips and reminders from Medicare also. They encourage hospices to submit groups of NOEs in separate batch transmissions from group claims. So you don't want to send one batch that contains both NOEs and claims. Separate them out. Send one batch of NOEs, one batch of claims. I think that's just good practice. All NOEs submitted manually and electronically are subject to the timely filing requirements. So just because they're giving us this electronic option, they're not changing any of the other rules regarding notice of elections and your 5-day timely filing window, and they won't give any additional exceptions. So it will continue to be determined by the receipt of the NOE that has processed and finalized in a paid status. So again, if you're submitting electronically, you know that just like a claim, you won't see that notice of election immediately over on the Medicare DDE system. You'll have to wait usually until the next day, depending on what time of day you send. If it's very late, it might be 2 days. So you can see where your 5-day window can quickly come to the end before you can see the claim. You definitely want to make sure if you are day 4 or day 5, I think I personally would hand key those claims just to be certain. Hand key the NOEs, because when you hand key it, you can see it immediately on the Medicare DDE side, so you can double check, make sure all of your data elements are correct. I would practice your electronic NOE submissions with, notice of elections for patients who are admitted, 1 or 2 days ago, not 3 or 4 days ago. The late NOE, the claim will still require to be submitted with the occurrence code 77 and the case modifier. And so, again, none of those exception rules have changed. Now, this is, I took this directly from the Medicare University handout, and this is the 837I requirements, which are the electronic requirements. And these are data elements that are not required when we hand key a claim. So these are like the differences that you necessarily don't see or we don't do when we hand key on DDE. So now your type of admission is required on an electronic claim. Your admission source is required, and it defaults to 1. Your patient status code should default to a 30. It requires a line item on your charge page, so your revenue code for that is 650 or 0650. Your HCPCS code is Q5009. So they're not requiring that you identify the location of your patient at the time of the NOE. They're asking that we use Q5009. A service date is required, so you would put your start date, your from date in your statement coverage period, same as the admission date. Your total units should be 1, and your total charges should be 0. So those are all of the data elements that are different than what we hand key now. Again, I think I talked about this. We recommend that each agency reach out to your MAC and your software provider to be certain the process is live and accurate, and we suggest when you test claims to be certain they are submitted and received successfully and the data required is present for processing. Remember, the electronic NOEs will process like claims, so you won't necessarily see them the same day, the next day. It might be 2 days, and you want to make sure you don't send test claims so close to your 5-day timely filing window that you may have a late NOE if it doesn't go over or if there's an error. So as a backup, we suggest that you continue hand keying claims and testing some claims, and maybe you want to test on your discharges instead of on your admissions. Maybe you send your 81Bs electronically and make sure that that process works before you submit NOEs. But we definitely suggest you watch it closely, obviously, since there will be no additional appeals granted over issues with electronic filing. So another electronic feature that Medicare has finally granted us is the ability to correct NOEs or NOTRs. So this is not necessarily an electronic feature, although I guess it could be. If you filed a notice of election and you need to file a new one, I'm not sure it would really require programming by your particular software to allow you to file a new NOE with the required data that actually replaces the NOE that was submitted with an incorrect admission date. So this was very confusing to me when it was initially presented, because it was presented like you could do it as an adjustment, and that is not the case. So you can't file a notice of election with an incorrect start date or admission date and then correct that actual admission. What you would be doing is filing a new NOE and using the occurrence code 56, report condition code D0, and the occurrence code 56 date will be the incorrect start date. So your new notice of election will have the correct start of care date and your correct 27 occurrence code date, but you will use the occurrence 56 and the date that you incorrectly used on your initial notice of election to basically, it will override, it will replace the incorrect admission date. And I know that sounds very confusing. I'm sorry if I'm not explaining it well, but initially we asked, they're giving us a condition code, but they didn't give us a reason code for the adjustment, and that kind of stumped the people we asked. And it's because, and this is just what I've gathered from it, it's not a true adjustment. We're not adjusting the initial incorrect notice of election. We're filing a new one and telling them by using the occurrence code 56 with the wrong date and the condition code DO that, hey, this is the correct notice of election and it is being submitted to replace the initial one with the incorrect information. So that is the way we process notice of election corrections. This is how it looks on your DDE screen. So you can see where they're entering the condition code D0. That's telling them why you're making this correction. And you can see that you've recorded your correct admission date in your admit field. And then in your occurrence field, you're still reporting your 27 occurrence code for the correct admission date. And then you're reporting an additional 56 occurrence code with the incorrect date. So that tells Medicare that this is a correction NOE. And we have the same type of process for your NOTR. So we'll, again, use the same condition code 56 and report, occurrence code 56, report condition code D0, and use your occurrence code 56 to report the incorrect date of revocation from the initial NOTR. So it will look like this. You're filling out the same fields now, except you're using your through date. You're going to report the correct date of discharge, and your 56 occurrence is where you put the incorrect date of discharge that you reported on your initial NOTR. So keep in mind that you have to have both the 56 with the date and the condition code D0, or it will return to provider. These are the resources that I pulled that information from. Again, that the Medicare University, some of those slides are straight from there, so you'll get that same data, but there's a few additional resources on the Medicare University handout, so you definitely want to go look that up. And Lastly, we'll talk about required workaround for hospices submitting routine home care claims and service intensity add-on payments at the end of life. So this is something we've talked about on the last 2 calls, and we tried to quantify how we were going to tackle looking at all of these claims, because Medicare gave us this, they issued MLM Matters SE 1714, telling us that we could manually adjust, or we needed to manually adjust claims that met certain conditions because they were incorrectly paid. And those claims are, the claims were, and these are the conditions that needed to be corrected. If the prior hospice days used are greater than 99, Medicare systems were calculating an incorrect payment. Now, Medicare supposedly put in a fix to eliminate that error on August 21st, which means that from January 1st of 2016 to August 20th of 2017, claims paid incorrectly if the patient met these conditions. So if the patient had a prior hospice for greater than 99 days with no 60-day gap between their care and your care for that patient, then Medicare did not take into account that the patient had prior hospice. So they started paying you at day 1, which is the higher rate, instead of day 100 plus, whatever that day might be, at the lower rate. So that's the issue with that particular error. The second, and this in their handout, it says routine home care visits, but I'm pretty sure that's a typo, and it should say days and not visits. Routine home care days are overpaid when there's a transfer within a benefit period, because the days prior to the transfer are not being recognized. So it's really the same issue. They're not counting the days prior to your admission, even though you know the patient had prior hospice because they transferred to you. So Medicare wasn't calculating those days and started paying you again at day 1 instead of at day whatever it might be. I mean, it could be anywhere after 1, but they're not taking into account the previously paid hospice days for a transfer in. So the other issue identified is with SIA payments, and it seems to be limited to patients who pass away in the first 7 days of a month. And what was supposed to happen is that the prior month should recycle automatically through Medicare's system, and if there were any qualifying SIA visits, those visits should have been automatically paid. So there's a question, first of all, some of those prior months were not auto-recycling, and others, when the agencies were recycling them themselves, were not picking up and paying those additional SIA payments. So for this, I would definitely recommend that your biller or someone in accounting or someone designated in your agency is looking specifically at these patients. And for some agencies, it's not very many patients. I'm sure for larger companies, it's a lot of patients that pass away in that first 7 days, and maybe no one is looking at that prior claim, the prior month's claim, because it's been submitted, it may have been processed and paid, and your software doesn't know that those visits that might qualify for SIA should bill as SIA because the patient's date of death had not occurred in the system at the time of the claim. So I'm not sure that anyone necessarily would know that money was not paid, because the claim probably paid the way it was billed, and so you're not recognizing that you're missing those additional dollars. So Medicare gave us these required actions. Hospices should now submit adjustments to claims with outstanding SIA and routine home care payment errors, except for those with the prior benefit days greater than 99. Now, I left this in because that was the original release, but obviously we're past August 21st, so now they're saying we can go in and correct those claims with the greater days, greater than 99 prior hospice days. So a lot of hospices, of course, had issue with this because for some agencies, I'm certain it was a lot of claims. And for us, it wasn't necessarily the volume of claims that needed to be adjusted, but it was the volume of claims that needed to be researched in order to know which claims we even needed to target to see if there was an adjustment needed or how it paid, did it pay at the right rate, and the calculations. So it was just a lot of legwork. And so when Medicare came back and said that they would give us a way to submit these claims on a spreadsheet to our MACs, but they didn't give us much time to do that. So let me back up just a little bit and talk about how to correct the transfer claim. So this, they did give us a very specific way to correct. If your patient transferred in and you were not paid correctly, then you can do an adjustment on the claim and put in your start date as the original admission date. So the hospice should enter the start date 1 in the current benefit period as the admission date on their claim rather than their own admission date. So if you have transferred a patient and the patient's in benefit period 4, they're saying you should adjust that claim and use your admission date, use the admission date of the start date 1. So whatever date period 1 for that patient started, benefit period 1, is the date you should use. And when you recycle the claim, you use the condition code D9, and in your remarks, you should put in adjustment due to RHC errors for FE 17014. So as confusing as that sounds, they're saying go back, look at your common working file, pull the original start date of the patient. And to be honest, I mean, just from my perspective, and this is just me talking, not Medicare, if your patient has 4 benefit periods in the common working file and you don't know, you cannot identify date 1 because maybe they're in period 9 or 10, I would think going back to the date of the oldest benefit period you can see and entering that date would give you more than enough days to get you past the 99. So that should work because your 4 start periods out, and even if it's 4 60-day periods, you should be okay. Unless those periods are shortened due to revocations and readmissions, and then you may need to call Medicare and actually get the hospice period start date for the very first benefit period. So jumping back to correcting on the spreadsheet, Medicare gave us SE 17029, and they released an addendum to SE 17014, which gives providers the opportunity to submit a list of claims that met the criteria of previous hospice of more than 99 days. However, they only gave us until October 20th to get those spreadsheets to our MAC. So for people who were waiting, now keep in mind, between the time they told us we had this problem and August 21st, there was a lot of hope and maybe some talk that when that fix came in on August 21st, that Medicare would be able to recycle these claims and would not have any provider action necessary. That was the hope, but obviously that didn't happen. So as providers were faced with researching all of these claims and figuring out which ones may need to be adjusted, Medicare puts this out on September 26th saying, okay, you can just give us a spreadsheet with the DCN numbers and the claim dates, and we will make those adjustments. But with only 3 weeks to research it and compile and submit, I'm not sure that any agencies of a larger size had the opportunity to complete the research and get it done in time to submit it by October 20th. So for those who did not, now this is just another point that I highlighted because I think it's really important. So in SE 17029, Medicare also indicated that they worked with an agency, each MAC worked with an agency to work on this process of doing these mass adjustments from a list or a spreadsheet. And the trial confirmed that there were some provider-submitted adjustments that in many cases had no effect on payment. So even though agencies were making those adjustments manually, that the adjustment was not resulting in the accurate payment, and that actions only the MAC can take are needed for the adjustments to process accurately. So that's not great news. I mean, so they're saying, first of all, if you miss the deadline to get the spreadsheet in, you have to do them manually, but we've found that manually doesn't always work. So we have reached out to someone at each MAC, and we've asked this question. So now that we're past the October 20th deadline for submitting a spreadsheet, how do we correct these claims? And unfortunately, I've not gotten that information back before this call. but I will make certain that everybody here gets the response that I receive, and we'll send it out on email, or we'll include it in the next newsletter to make sure that we can share that information with you. Basically they're telling us that manual adjustments were not working at the time of publication. We've received no update so far that I can find, and I've been looking, and I've received emails from all of the MACs for all updates. We don't have specific instructions for manually adjusting the claims. Of course, we know how to adjust it, but if the adjustment is not resulting in the correct payment, then we may be wasting our time doing those adjustments. And to adjust a claim multiple times is not always possible, so we don't want to necessarily put in an adjustment that doesn't result in the desired action and then have to adjust it again, or have the MAC adjust it again. So again, as soon as we have a resolution and we know it works, we publish it through the newsletter and also on the next webinar. And we've given you the link to SE 17029 at the bottom of this slide. So I know that is a lot of information to digest, and if anybody has questions, we can take those questions now. So if you could type them in, I'll give a few minutes to everybody. If anybody has anything, I'll be happy to answer that. And, again, if you come up with something after this call, you can certainly email it to us, and we will answer it to the best of our ability. And if for some reason I can't answer it, I will reach out to a MAC and get an answer for you. So I would like to know also, we ask for feedback on every call and every newsletter. So I would like to know if any of you guys are successfully submitting electronic notice of elections now. And if you wouldn't mind sharing what software vendor you're using, because it's nice to know which ones are ready. We deal with a lot, but certainly not with every software vendor out there. So we would just like to know how far along we are in this process and how successful agencies across the country have been. So we would certainly want to know if you guys are sending these and if they're being accepted, and if you're having any issues. I can tell you just from experience that there's been a couple of times that we have submitted notice of elections through another method electronically, and there were some data fields on the claim that should not have been populated, and so those caused the problem. So we just want to hear about good, bad, ugly, anything that's working or not working with this electronic process. We would also love to hear if you have successfully submitted a claim spreadsheet for these adjustments to your MAC, and if those adjustments have been completed. I believe they are supposed to be completed by the end of January, if I'm not mistaken. So that would be great to know as well. And if you haven't submitted a spreadsheet, if you were not ready to do that, which a lot of us were not, we just would like to know how you're tackling that research, how much manpower it's taken in your agency, and are you close to completing your corrections? Let's see, and I have a question here. I want to make sure I understand. If we can't determine which claim. Okay, so here is my question. I just want to make sure I understand. If we can't determine which claim, how many need to be readjusted? Currently, there are not repercussions for not submitting for the corrections. As far as I know, there are not, and I've seen also a publication that stated that those adjustments should not be listed on your credit balance report because, again, it's impossible to quantify if you haven't looked at every single claim, and I believe Medicare, because their system didn't calculate it correctly, they're not penalizing the agency for that. But I think, and this is my opinion, that eventually Medicare may go back and recycle just a certain number of claims every quarter until they recycle them. And I don't know if you guys have had this experience, but we've had in home health on, years past that they recycle claims that are 2 and 3 years old. And so it's like eventually they get to a point where they either have the capacity or they are sure that the system is working properly to recalculate those claims. And so they start recycling them. So, maybe that'll happen and maybe it won't. I just kind of feel like if you want to know financially how it will impact your agency, it's much better to take that responsibility and do those corrections yourself in your own time over the course of however much. I mean, they've given us, we're beyond timely filing on the 2016 claims, and they just, as long as we put the remarks in that we're correcting for whatever SE number we need to use, they're going to process. So I don't think this is a huge financial impact for most agencies. I think, you will get a few SIA dollars, and you may have to pay back a few high rate days, but I don't feel like it's a huge number of dollars. But again, that's just my experience with the agencies that we work for. So I'm not sure how it will impact each individual agency. I think it's worth taking the time to look at your claims, and anybody in a software can pull reports for admissions, pull reports for discharges and transfers, throw those on a spreadsheet. I mean, I know that makes it sound easy, but it is time consuming. And then look at those claims individually and determine if they meet the criteria for needing an adjustment. You do have to know your daily rates. You have to know the daily rate at the time of the claim because, of course, they change annually. So there's a lot of information that you will have to put on the spreadsheet. We had created a spreadsheet, and we published it in a newsletter prior and on a webinar prior to this one. And since then, we've actually refined it and changed it up a little bit to just give us the data we actually really need. So we are happy to share that spreadsheet. I mean, it's just a blank sheet with the headings that kind of tell you what information you need. But we built those sheets based on the format of the reports we're able to pull from the software systems that we work in. But it would give you an idea of what you need to do to accurately identify these claims and go down the list. And if it doesn't need an adjustment, we just mark it out in whatever color. And if it needs an adjustment, we mark it out, we put what the rate should have been, and then we go into DDE and confirm what we find and make those adjustments manually. So to answer your question, I know that was a long answer, but there are no current repercussions that we've seen, except that it was a Medicare directive. I mean, Medicare says, here's the action required by the provider. So when they tell us there's a provider action required, we take that as, we need to do it. Again, they've not given us a deadline for timeliness on this, and we are past timely filing, and they're giving an exception for that. So, I don't think it's something that we need to take all of your resources to put into this, but I do believe it's something that maybe you carve out an hour a day, a couple hours a week for the biller or someone in that office to be looking at these claims, putting this spreadsheet together, doing the research needed, and then to sit down and determine which corrections or adjustments you want to process first. We're working oldest to newest, and month by month, that's our process and system that we have in place right now. So we're changing it daily. We try to do the best we can to use our time wisely and be as productive as we can in this and not spend a whole lot of time if we can avoid it. But no matter how we slice it, it has taken quite a lot of time for our billers to research. But we have quite a few agencies, so there is a volume issue with us. I don't know that each of you guys have a huge number of patients, so it may not take any time at all. So that was the only question that I have in my box. I don't know if anybody else has anything. So that's really all that I have. I want to thank you guys again for joining us, and also to please ask that you submit any questions, concerns. If there are issues you would like to see us cover in the newsletter or on the webinar, which usually one follows the other, so we'll cover it in both places, please send that to us. We always want to be a resource for anyone that needs additional information from Medicare through your MAC. Anything related to billing and collections we can certainly help with. So please submit those questions to me. If anybody, if there's anything we can help with, if you have billing questions in general, of course, that's our specialty. So we are more than happy to help you with that. And if you need billing services, of course, we want you to give us a call, because we want to do exactly what we do best, which is collect more of your money faster so that you guys can take care of the patients in your community. So thank you all for joining us. And again, email me if I can help any further, and we look forward to you guys joining our next webinar in February. Thank you.